Welcome back to Rad Onc Smart Review Head and Neck Edition. Today we're doing episode 30, which is a big one, Larynx Capstone, a mock oral board review. We're going to simulate the oral board exam in 4 distinct clinical blocks. And this is a strict role play. I'll be the senior attending, the examiner. I'm going to control the flow, present the cases, ask the questions, and I'll deliver the teaching pearls along the way.
And I'll be the resident examinee. I'll be answering the questions as if I'm right there in the hot seat, trying to demonstrate the clinical reasoning and the structured answers you need to pass.
That's right. So each block has a case that will escalate through workup, staging, treatment selection, and so on. And we'll close each one with a twist, a complication that really tests a key decision pivot. For you listening, I want you to treat this like a live exam. Use the pauses to think up your own answers before you hear our examinee respond. All right, let's begin.
I'm ready.
Block 1, T1A glottis. We're going to be looking for correct staging, field design, fractionation, and, very importantly, management of the neck. Here is your case. You have a 67-year-old male. He's got a 40-pack year smoking history, but he did quit 6 weeks ago. He presents with 3 months of hoarseness. The NPL shows a small lesion, middle third of the right true vocal cord. The cord is fully mobile. There's no extension to the anterior commissure or the subglottis. CT of the neck is negative for nodes. Biopsy confirms squamous cell carcinoma. So the stage is T1A, N0, M0, a glottic squamous cell carcinoma. What are the treatment options?
Okay. For a T1A0, M0 glottic squamous cell carcinoma, there are 2 excellent curative standard of care options. The first is definitive radiation therapy. The second is transoral endoscopic surgery, which is, typically transoral laser microsurgery. Both of these modalities have really excellent local control rates, historically over 90%. So the decision often comes down to functional outcomes and logistics.
Okay, good. Elaborate on those functional differences for me.
The main functional metric we're looking at is voice quality. And while both treatments offer good voice outcomes, there's some retrospective data that suggests radiation might provide a superior objective voice quality, specifically things like jitter and shimmer. That's compared to surgery, which, you're physically removing tissue from the vibrating cord. But on the other hand, surgery is a one-day procedure. Radiation is a multi-week daily commitment.
So how do you make that final decision?
I would have a detailed discussion about these trade-offs with the patient. The factors would be his preference, of course, his ability to come in for daily treatments, and also the surgeon's ability to get good exposure of the larynx. If a patient has, say, difficult anatomy for laryngoscopy, radiation really becomes the preferred choice. Assuming he prefers radiation, I would fully support that. It's a Category 1 recommendation.
Okay, and that's a teaching pearl right there. For everyone listening, acknowledge the options, then commit. Don't waffle. Examiners want to see you weigh the evidence, in this case, voice quality versus convenience, and then make a clear, definitive call. So in this case, the patient chooses radiation. Walk me through your simulation and your field setup.
Okay. I would simulate the patient supine. I'd use a thermoplastic mask for immobilization to make sure everything is reproducible. And I'd place the neck in mild extension. This just helps displace the chin superiorly, clearing it from the treatment field.
And would you use a bite block?
No, I would not use a bite block. A bite block is really for oral cavity or pharynx cases. You use it to depress the tongue or separate the jaws. For a larynx case like this, it offers no advantage, and it could actually alter the larynx position or just cause discomfort.
Correct. So what's your field arrangement?
For T1 glottic cancer, the classic and highly effective arrangement is opposed lateral fields. So that's 2 parallel beams, typically 6 MV photons, and we're treating just the larynx.
Define your borders. Be precise.
Okay. Superior border, I would place the field edge right at the thyroid notch. That corresponds anatomically to the top of the thyroid cartilage. There's really no need to go higher. The true cords are well below that. For the inferior border, the edge goes at the bottom of the cricoid cartilage. That makes sure we cover the true cords and the immediate subglottic region, which is the anatomical limit we're targeting.
And what about that posterior border?
The posterior border is critical for sparing the spinal cord. I would place it anterior to the vertebral bodies. I want to cover the posterior aspect of the thyroid cartilage and the arytenoids, but the field edge needs to fall off before it hits the bone. It creates a very tight posterior margin.
And anteriorly, what's the key word there?
Anteriorly, I would ensure flash. This means the field extends beyond the skin surface into the air.
Why? Why do we do that?
2 main reasons. First is to account for setup uncertainty and, potential swelling. If the patient moves or the neck swells, we don't want the skin surface to move out of the high-dose area. And second, It's to ensure electronic equilibrium at the skin surface. High-energy photons need a buildup region, so by flashing the beam, we guarantee that the anterior commissure, which is very close to the surface, gets the full prescription dose.
Excellent. Another teaching pearl for you. Examiners are looking for tight larynx-only fields and anterior flash. That flash is absolutely non-negotiable, especially for anterior commissure coverage. What's a typical field size here?
Oh, these are small fields, typically about 5 by 5 centimeters, maybe 6 by 6 centimeters at most.
Okay. Now let's get into dose and fractionation.
I would recommend hypofractionation. That's really the standard of care for early glottic cancer. My preferred regimen would be 2.25 gray per fraction.
To what total dose?
I'd treat to a total dose of 63 gray in 28 fractions. An alternative, which is also perfectly acceptable, is 65.25 gray in 29 fractions.
Why not use 70 gray in 35 fractions? That's the standard for almost every other head and neck site.
Well, early glottic cancer is just. It's distinct. It's a small volume tumor. There's limited hypoxia compared to, say, a bulky node. Radiobiologically, it's been shown to respond very favorably to larger fraction sizes. The clinical trials and large retrospective series have all shown that hypofractionation, using that 2.25 gray per fraction, it gives you local control rates that are equivalent, if not superior, to conventional fractionation, and it shortens the treatment time for the patient. Using 70 gray and 2 gray fractions is just, it's unnecessary here.
Perfect. Teaching pearl. Be concrete. You don't have to oversell the radiobiology. Just state what the data supports. Hypofractionation is standard for T1 glottis. That's all you need.
Nah.
Next question. Do you electively treat the neck?
No, I do not treat the elective neck nodes.
And your rationale?
The true vocal cords have very sparse lymphatic drainage. The risk of occult nodal involvement for a T1 or T2 glottic tumor is exceedingly low. Historically, it's less than 5%. So the toxicity of irradiating the neck, xerostomia, fibrosis, it just outweighs the negligible risk of nodal failure. I'm treating the larynx only.
Good. That is a trap question. Another pearl. No elective neck for early glottis.
Yeah.
If you hesitate on that, you lose points.
No.
Now, here's the twist.
Okay.
The case changes. The lesion now extends to the anterior commissure. How does this change your planning or your management?
Okay, so extension to the anterior commissure is a high-risk feature. The staging might still be a T1A or T1B, but the anterior commissure is a site where the tumor can access cartilage more easily, and it's notoriously difficult to dose adequately because of that air-tissue interface.
So do you switch to surgery?
Not necessarily. Radiation is still a very strong option. Some would even argue it's preferred because surgical exposure of the anterior commissure can be really difficult. But my planning becomes much more rigorous. I absolutely must verify that the flash is adequate. I would specifically check the dose distribution at the skin surface anteriorly, just to make sure there's no underdosing. I might consider bolus if the dose of the commissure is insufficient, but with good flash and opposed laterals, it's usually covered.
Do you treat the neck now?
No. Even with anterior commissure involvement, if it's still a T1 glottic cancer, the lymphatic drainage is still sparse. The risk of nodal metastasis doesn't jump up enough to warrant elective neck irradiation. So, no, I'm still treating the larynx only.
Final question for this block. The patient finishes treatment. 6 months later, he's hoarse again. Biopsy confirms recurrence. What's the plan?
This is a local failure. The standard of care is salvage surgery. The options would include a partial laryngectomy if the anatomy allows for it, or a total laryngectomy. The salvage rates are very high. I think less than 1% of T1 patients ultimately succumb to the disease because salvage is just so effective.
Excellent. Final pearl for the block. Early glottis is highly curable. Know the metrics. 2.25 gray per fraction, no elective neck, and anterior commissure means high risk, but still no neck treatment. Salvage is surgery. All right, let's move to block 2. T3N1 supraglottic organ preservation.
Understood.
Here's the case. A 58-year-old male, active smoker, active drinker. He presents with progressive dysphagia and a neck mass. Workup shows a bulky supraglottic mass involving the epiglottis and the false cord. The true cord is impaired, but it is mobile. The preepiglottic space is involved. There is a 3-centimeter necrotic node in level 2. So the stage is T3N1M0 supraglottic SCC. The question is he a candidate for organ preservation?
Yes, potentially.
Okay, walk me through the criteria for that.
Yeah. Well, to be a candidate for organ preservation, the patient has to have a functional larynx at baseline. This means he needs to be able to breathe without a tracheostomy and swallow without significant aspiration. In this case, his true cord is mobile, even though it's impaired, and there's no mention of severe airway compromise. So he meets the functional criteria.
And what are the exclusions? What would make you say no?
He must not have any unpreservable features. So specifically, he shouldn't have gross destruction of the thyroid cartilage or a tumor penetrating through the cartilage into the soft tissues. And he shouldn't have massive invasion of the base of tongue, that's generally defined as more than 1 centimeter of invasion. This patient has a bulky T3 tumor. It involves the pre-epiglottic space, which is classic for T3 supraglottic. But as long as that cartilage is intact, he is a candidate.
What about the smoking?
That's the potentially part of my answer. Active smoking is a huge adverse factor. It increases the toxicity of chemoradiation, especially mucositis and laryngeal edema, and it definitely decreases the probability of local control. I would counsel him very strongly that while he's an anatomical candidate, his success really depends on immediate cessation.
Good. Another pearl, the yes but response. Affirm the candidacy, but then list your exclusion checklist. A functional larynx is absolutely key, so what's your treatment recommendation?
I recommend definitive concurrent chemoradiation.
State your evidence.
The landmark trial here is RTOG 9111. This was a randomized control trial for stage 3 and 5E larynx cancer patients who were candidates for preservation. It compared 3 arms: radiation alone, induction chemotherapy followed by radiation, and concurrent chemoradiation with cisplatin.
And what did it show?
The concurrent chemoradiation arm showed the highest rate of larynx preservation. It was better than induction or radiation alone. It's now the gold standard for maximizing the chance of keeping the voice box.
Did it show a survival benefit?
That's a great point. Interestingly, no. The overall survival was not statistically different across the arms in the long-term updates, but the concurrent therapy had excellent locoregional control. And the primary endpoint preservation of the larynx was clearly superior with the concurrent approach.
Right. Pearl. Concurrent CRT is the winner for preservation. Be careful not to claim it improves survival over surgery, but it absolutely maximizes preservation. Now, target volumes. This is a supraglottic tumor. How does this differ from the glottic case we just did?
It's completely different regarding the lymph nodes. The supraglottis is embryologically distinct from the glottis, and it has this rich bilateral lymphatic drainage network. So unlike the glottis, where we only treat the primary, for a supraglottic tumor, we absolutely must treat the bilateral neck.
Which levels?
I would treat bilateral levels 2, 3, and 4. And given the N1 disease in level 2, I would likely include level A and V on the involved side, potentially bilaterally, depending on the full extent.
What about level 6?
Level 6, the anterior central compartment, is typically spared in supraglottic cancer, unless there is subglottic extension. The drainage of the supraglottis goes laterally to the jugular chain, not down to the paratracheal nodes. Since this patient has no subglottic extension, I would not treat level 6.
Exactly. Teaching Pearl. Supraglottic equals bilateral neck. No subglottic extension equals no level 6. This saves the thyroid gland. Now, counsel the patient on the risks.
I would explain that while our goal is to save his voice box, the treatment itself is very aggressive. The risks include a severe sore throat, dermatitis, loss of taste, thick phlegm during treatment. And long-term, the biggest risks are dry mouth, hypothyroidism, and most importantly, a permanent difficulty with swallowing.
Go a little deeper on the swallowing issue for me.
Sure. The radiation causes fibrosis of the pharyngeal constrictors and the larynx itself. So even if the cancer is cured, the larynx might become stiff and not close properly. This can lead to chronic aspiration, a preserved larynx that doesn't actually function, meaning the patient needs a feeling tube. That's a poor outcome. And I would absolutely reiterate that if he continues to smoke, all of these risks just skyrocket.
Okay, here comes the twist.
Ready?
The patient is 4 weeks into treatment. He develops stridor. He is audibly wheezing in your waiting room. What is your immediate move?
I have to evaluate his airway immediately. I bring him to an exam room, keep him sitting upright, and perform a fiber optic exam right then and there. If he is in any distress, I'm calling for emergency airway support, anesthesia, and ENT stat.
He's stable but stridorous. What's your differential diagnosis?
It's one of two things. It's either edema swelling from the radiation and tumor necrosis, or it's tumor progression.
How do you manage it?
I would immediately start high-dose steroids, like dexamethasone, to try and reduce that edema. I'd also likely place him on antibiotics if there's any sign of a superinfection. Then I'd reassess his response very closely. If the airway improves with the steroids, that suggests it's edema, and I can carefully continue his treatment. But if it doesn't improve, or if the tumor looks visibly larger despite 4 weeks of therapy, I have to consider that the preservation strategy is failing.
Scenario update. The stridor improves. He finishes treatment. 3 months later, on follow-up, you see a residual mass. You biopsy it. It's squamous cell carcinoma. What now?
This is a failure of preservation. He has persistent disease, The only option now is salvage total laryngectomy.
And what are the risks of that salvage surgery?
Salvage surgery in a previously radiated field has a much, much higher complication rate compared to upfront surgery. The risk of a pharyngocutaneous fistula is significantly higher. Some series quote around 30 to 40%, just due to poor wound healing. But it is his only curative option.
Right, Pearl. Preservation failure requires salvage laryngectomy. It's a high-risk surgery, but it's necessary. And always confirm persistence with a biopsy before you condemn the larynx. Okay, block 3. T4NN0 glottic when not to preserve.
Okay.
Your case? A 62-year-old male, heavy active smoker. Workup shows a large glottic mass, a fixed cord. CT and MRI show sclerosis and erosion of the thyroid cartilage. There is extralaryngeal soft tissue extension into the strap muscles. Stage. T4A N0N0. Question. Is he a candidate for organ preservation?
No.
Why not? We just discussed chemoradiation as a standard for advanced laryngeal cancer.
He is not a candidate because he has T4A disease with gross cartilage destruction and extralaryngeal extension. This is really the definition of an unpreservable anatomy.
Explain the logic behind that.
Well, the goal of preservation is to end up with a functional larynx. When a tumor has destroyed the cartilage framework and invaded the strap muscles, the larynx is just structurally compromised. Even if radiation sterilizes the cancer, that cartilage will not regenerate. So the larynx will be a non-functional, probably collapsed structure that's prone to chronic aspiration and pain. Also, tumor that's inside cartilage is in a sanctuary site, poor blood supply, which makes it more radioresistant.
And what evidence do you have to support avoiding radiation here?
The VA larynx trial, which is the trial that established preservation, actually showed that for T4 tumors, specifically the ones with high volume cartilage invasion, the rate of salvage laryngectomy was very high, something like 56%. So that means the majority of these patients ended up losing their larynx anyway, but only after enduring a failed course of chemoradiation first. And RTOG 9111, the other big trial, it excluded patients with this degree of gross cartilage invasion. So we can't extrapolate those good results of this patient.
Exactly. Teaching Pearl. Your board safe phrase is this. Bulky cartilage penetrating T4A with extralaryngeal spread is not a preservation candidate. So what is your recommendation?
I recommend upfront total laryngectomy followed by adjuvant therapy.
And why is that a better path for this patient?
It provides the most reliable local control and the best chance of cure. It also removed the dysfunctional destroyed organ from the start. It avoids the toxicity of high-dose radiation to a laryngeal skeleton that just cannot heal. And post-laryngectomy, patients can undergo voice rehabilitation with a tracheoesophageal puncture. And they often have a better quality of life than patients with a preserved but totally useless larynx.
No, counsel him. He is, understandably, terrified of losing his voice.
I would sit down with him and say something like, I know that the thought of losing your voice box is devastating. I completely understand. However, the cancer has already destroyed the structure of your voice box. If we try to treat this with radiation, there's a very high chance the cancer won't go away, or that you'll be left with a voice box that doesn't work. That could mean needing a permanent breathing tube and feeding tube anyway, but with the cancer still possibly there. Surgery gives us the best chance to cure you. And after surgery, we have excellent ways to help you speak again using a prosthetic voice valve. I truly believe surgery is the safest path to get you back to living your life.
Okay, here's the twist. Patient refusal.
Okay.
He hears you. He understands. And he says, Doc, I'd rather die with my voice box. He refuses surgery.
The first thing I have to do is assess his capacity. Does he truly understand the risks of his decision? Does he understand that choosing radiation significantly lowers his chance of a cure and might leave him with a useless, painful larynx?
He does. He understands perfectly. He has capacity. He still refuses.
Then I have to respect his autonomy. I can't force him to have surgery. I would document his refusal of the standard of care extensively in the medical record. And then I would offer him the best non-surgical option we have, which is concurrent chemoradiation.
How did your management change now that you're on this path?
I would follow him extremely closely. Weekly visits, frequent scopes. I would set very strict parameters for response assessment. If at any point during or immediately after treatment there is clear progression or lack of response, we have to revisit that surgery conversation immediately.
Okay, here's the outcome. He treats with chemoradiation. 8 weeks post-treatment, scans show stable disease. However, he is tract-dependent and peg-dependent because he aspirates his own saliva. Is this a success?
No, absolutely not. This is a failure. We achieved anatomic preservation. The cartilage is still physically in his neck,
Yeah.
but we completely failed functional preservation.
Yeah.
He cannot use his larynx for breathing or for eating. In fact, a non-functional larynx like that is often dangerous because of the high risk of aspiration pneumonia.
So what do you do now?
I would have another serious talk with him about a laryngectomy, but this time for functional reasons, as well as for definitive cancer control, because stable disease at 8 weeks is very concerning for persistence. Removing that non-functional organ might actually improve his quality of life. It could allow him to eat safely and maybe even use a TEP rather than struggling with a peg and a track for the rest of his life.
Great. Teaching Pearl. Anatomic preservation without function is a failure. Be very clear about that distinction. Okay, last block. Block 4. Post-laryngectomy, positive margin, and ENE.
Right?
Case presentation. 64-year-old female. She is status post-total laryngectomy for a T4A and 2B. The pathology shows PT4A with cartilage and soft tissue extension. There's a positive inferior tracheal margin. The right neck had 3 of 22 nodes positive, and 2 of those had extranodal extension, or EN. Subglottic extension was present. PNI and LVSI are also present. The question, radiation, chemo, or both?
She needs both. Concurrent chemoradiation.
And what are the specific triggers for that?
She has the 2 absolute high-risk indications for adding chemotherapy to postoperative radiation. First, a positive margin. Second, extranodal extension, ENE.
Reference the data for me.
This is based on the pooled analysis of 2 major trials, RDOG 9501 and EORTC 22931. These trials randomize high-risk post-op patients to either radiation alone or radiation plus concurrent cisplatin. And the analysis showed that the benefit of adding chemotherapy for local regional control and disease-free survival was driven almost entirely by the subgroups with positive margins and ENE.
What about the PNI and LVSI? Aren't those bad?
They are. They are intermediate risk factors. They're definitely indications for postoperative radiation therapy, but in the absence of a positive margin or ENE, they don't mandate adding chemotherapy. The toxicity of chemo is significant, so we reserve it for only the highest risk features.
Perfect. Teaching Pearl. Positive margin and ENE are the category 1 triggers for chemo. Everything else is a trigger for radiation. Now, the stoma boost, does she need one?
Yes, absolutely.
Oh.
The stoma is a very high-risk site for recurrence, particularly when there is subglottic extension or tracheal involvement. And this patient has multiple risk factors. She has subglottic extension, a positive tracheal margin, and PT4A disease with soft tissue extension. That whole constellation of findings makes a stomal recurrence a very real danger.
How do you dose it?
I would boost the stoma to a high dose, typically 60 to 66 gray.
Yes, Pearl. List the triggers in your head. Subglottic extension, positive tracheal margin, ENE, soft tissue extension. If you have those, you boost the stoma. Now, talk to me about volumes.
I would define 3 dose levels. My high-risk volume getting 66 gray would cover the area of the positive margin of the tracheal stump and the nodal level that had ENE. My intermediate risk volume to 60 gray would cover the entire operative bed, the stoma site itself, and all the dissected neck levels. And importantly, because she had subglottic extension, I must include level 6, the central compartment, in this volume. And then a low-risk volume to 54 or 56 gray would cover any elective undissected neck levels that remain at risk.
Explain that level 6 indication again. Why is that so important?
In a post-laryngectomy patient, if there was subglottic extension of the primary tumor, the paratracheal lymph nodes level VI are at very high risk. Therefore, the radiation field has to extend inferiorly to cover those paratracheal beds and the superior mediastinum, usually down to the level of the carina or even the aortic arch, depending on the extent.
Right. In a practical Pearl, a stoma boost means treating the skin and the hole. You often need a bolus to ensure that skin gets the full dose, since high-energy photons have a skin-sparing effect. All right, last topic, timing.
I would aim to start radiation within 6 weeks of the surgery.
Why that time frame?
To minimize the repopulation of any microscopic disease. We talk about the concept of total package time. Ideally, the time from the day of surgery to the last day of radiation should be less than about 11 to 13 weeks. Extending beyond that has been associated with lower cure rates.
Okay, here is the final twist, fistula.
Understood.
It is 6 weeks post-op. She develops a pharyngocutaneous fistula. Saliva is leaking from her neck. The surgeon is managing it conservatively. Do you start radiation?
This is a really complex, multidisciplinary judgment call. But generally, we do not start radiation in the setting of an active, uncontrolled fistula. Radiation inhibits wound healing. If you radiate a fistula, you can cause tissue necrosis, carotid blowout, a permanent non-healing wound. It's very dangerous.
So you wait.
Yes, typically we have to wait for it to stabilize. Now, if the fistula is very small and well controlled, some places might proceed, maybe trying to shield the fistula site if possible. But if it's large or infected, we have to wait.
It finally heals. You start at 8 weeks post-op.
That's acceptable. It's not ideal, but it's a necessary delay. I would document the medical necessity of that delay very clearly. And I would still treat with concurrent chemoradiation because her high-risk features, the positive margin and E&E, they haven't gone away. If anything, the delay makes the therapy even more critical.
Exactly. Final pearl for the day. Package time matters, but safety always comes first. Do not radiate a wide-open neck wound. Stabilize, then treat. We've covered all 4 blocks. Let's recap with some rapid-fire pearls. Early glottis.
2.25 gray per fraction. No elective neck. And watch the interior commissure.
Supraglottic preservation.
A functional larynx is required. The trial is RTOG 9111. Concurrent chemoradiation is best. And always bilateral neck treatment.
Unpreservable T4A.
That means cartilage destruction. The answer is upfront laryngectomy. The VA larynx data shows a high failure rate with preservation in that group.
And post-laryngectomy.
Chemo for positive margin and
Yeah.
E&E. And you need a stoma boost for subglottic or tracheal involvement.
That concludes our Larynx Capstone. You should now have the tools to navigate the oral boards for this critical subsite.
Thank you. This is very helpful.
Next time, we'll tackle the hypopharynx. We're calling it the worst actor paradigm. We'll discuss why it has the worst prognosis and how our management strategies have to adapt. Go to radoncsmartlearn.com for more cases. This has been the Rad Onc Smart Review. Sign off.